I okay. It stopped for right now, but it sounds like they're banging like pipes
Oh
underneath of
no,
me. Actually,
that's not good. Yeah, maybe you can hear it more in my office.
yeah,
Um, so I'm about to go off camera because of how
yeah.
congested I am.
Please
But I'll do you want me to share the slide now and post it? Okay, I'll do that.
do that.
Sounds good.
Let me make sure the chat is enabled for everybody. Mm, That is good. Okay, and that one. Perfect.
Bit Lily.
Thank you. Welcome, everyone. Thanks for joining us today. We are going to get started in just a few minutes. In the meantime, please feel free to introduce yourself in the chat. Just make sure that you select everyone when you're using the chat function. I am going to stop sharing this and let's try sharing your PowerPoint just to make sure everything with that is good to go.
How does that look? There. Are you able to see that?
Yes, we can see that. It's at, I don't know if that's the first slide or not, but we can see.
Oh, sorry. That's there we go.
Perfect. All right. We will wait another minute and then we will get started. Okay, it is 12 o'clock. We will get started. I apologize if you hear banging behind me. It sounds like they're doing some construction in the building. So I'll mute myself during the presentation. But welcome everyone, and thank you so much for joining us today. My name is Lily Stavisky, and I am the Outreach and Training Coordinator for BHIPP. And I will be introducing our presenter for today and facilitating the Q&A at the end of the session. Just a couple of housekeeping things before we get started. So your cameras and microphones are disabled. So please use the chat function for any questions, comments, or if you need support. You can also use the Q&A function for questions. And there's going to be 10 to 15 minutes at the end of the presentation for some questions. If you're participating today to receive CME or CU credit, you will need to attend for 45 minutes or more to receive your certificate. And all participants who'd like to receive credit will need to complete the evaluation survey after the session, which will be placed in the chat. And we will also send out to you guys via email afterwards as well. And all CME and CU certificates will be sent out by September 20th, which is next Friday, along with a link to the recording for today's sessions, the slides, and a list of related resources. And all those materials will also be uploaded to our website next week as well for you guys to access. So for those of you that are unfamiliar with BHIPP, I'd just like to provide some information about our program. Maryland Behavioral Health Integration and Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals in addressing and managing the mental health concerns of their patients. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. And the BHIPP Warm Line is staffed by a team of child mental health specialists, and it's available Monday through Friday from 9 a.m. to 5 p.m. And we will put our phone number and website in the chat for you. It is my pleasure to introduce today's BHIPP webinar, Surveillance and Screening in Primary Care Settings, presented by Dr. Antonia Gerard. Dr. Gerard is an assistant professor and licensed psychologist within the Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. She graduated from Nova Southeastern University in Fort Lauderdale, Florida in 2014 and completed her postdoctoral fellowship at Mount Washington Pediatric Hospital in Baltimore, Maryland. And during her time there following her fellowship, she developed an early intervention program and psychology's role within multidisciplinary pediatric clinics. She currently conducts psychological evaluations through the Center for Infant Study and BHIPP, and she supervises Healthy Step Specialists, which are early childhood development experts that are embedded in pediatric primary care and family medicine practices. We are very grateful to have you here today with us, Dr. Gerard. Thank you so much for sharing your expertise with us, and I will hand it over to you.
Awesome, thank you. I'll go ahead and jump right in to make sure that we have time at the end for questions. I have no conflicts of interest. Some of the things that we're going to be going over today are reviewing the differences between surveillance and screening, primarily in early childhood, and then identifying specific screening measures, both for early childhood and then across the child age span through adolescence, and how to review the results of these screeners with patients and their families. So starting with surveillance and screening, there is a difference between the two of those. Surveillance is something that occurs on a continuum, starting from birth and especially through age 5, though can continue throughout childhood, whereas screening typically occurs during specific intervals. Of note, the AAP does recommend surveillance continue at least through the 4- and 5-year visits as children are preparing to enter elementary school, but again, encourage for families to continue to monitor any changes in functioning throughout childhood. So this just gives more information regarding the difference between surveillance and developmental screening. So surveillance involves observing specific ways children play, learn, speak, act, move in ongoing ways. It often involves tracking a child's developmental milestones, using some kind of checklist, and can be done by really anyone in the child's life. So parents, teachers, health providers, whereas screening is a more formal process and involves using validated screening tools at specific ages to better determine if a child's development is on track or whether a referral is required for additional evaluation. And these screeners should be completed only by trained professionals. And both are very important in order to ensure that children are on track for their developmental milestones and receive any services should concerns arise. In terms of how to approach surveillance in practice, we'll discuss each of these a little bit more in depth, but this is an overview of the different components that make up successful surveillance. So first, we want to use specific questions to elicit and attend to parental concerns. These are primarily open-ended questions to allow for conversation. So some of these questions that are recommended to be used are, what are some things you and your baby or young child do together? What are things your baby likes to do? Is there anything that your baby isn't doing or does do that concerns you? And are there any skills that your baby or child has lost that they once had? Also, something that's important to note is we want to use language that's going to be less alarming or ominous to parents or caregivers. So using words like concerns versus worries. Also pairing learning and behavior with development helps parents understand and know what you're wanting them to talk about, and in order to make sure that we're addressing all of the concerns that a caregiver may have. It's also important to maintain a developmental history. This can be then reviewed over time to see if there are any abnormalities or deviations from what is expected by being able to reference previous notes. Also super important is observing the parent and child interactions. So seeing how the caregiver attends to the child, how well are they able to read and respond to the child in developmentally appropriate ways, how comfortable is the child around and in response to the caregiver, and then also wanting to make note of child and caregiver strengths. So if you're noticing that the caregiver is engaging in positive interactions with the child, pointing those out, as well as signaling empathy while the caregivers are raising any kinds of concerns. So trying to make the appointment as positive as possible and giving that positive reinforcement when you're able to. And then providers should also identify strengths, risks, and protective factors. So some of these risk factors would include things like prenatal exposures, birth complications, perinatal infections, any specific medical conditions like lead poisoning, congenital heart disease, any genetic conditions, as well as any adverse childhood experiences. So things like food or housing insecurity, exposure to racism, abuse, neglect, and any parental mental health issues, substance use, unemployment, if the child has teenage age parents, as well as understanding any limitations in terms of the parents' education or literacy, and then also some of those protective or resilience factors. So things like a strong connection with supportive family, active parent-child engagement, and opportunities to grow their independence in a safe, appropriately structured environment. Oops. And so those are all things to kind of consider when assessing for those risk and protective factors. And then also, of course, communicating with other important providers to make sure that everyone is on the same page and receiving the same information. So research shows that parent concerns are often very accurate and as accurate as quality screening tests. So parents raise important concerns regardless of their level of education, their child rearing experiences, and they're also typically the first to notice any concerns with their child's development. So because of this, it's important for providers to be intentional and ask parents if they have any concerns, and to do so multiple times and in different ways to really normalize that parents can and should share their concerns with you. And especially because they may be thinking that well-child visits or sick visits or any other kind of primary care visits should be more medically focused, allowing them to understand that also any developmental and behavioral concerns should also be addressed in these visits as well. And just something to note, the most common concern that parents often bring up, and I'd be curious to know if this is also your personal experiences as well, would be delayed speech. That tends to be the predominant concern that parents will bring up or address. So we want to encourage parents to monitor milestones, partner with any kind of daycare, early childhood programs to monitor these milestones, conduct early childhood screenings if surveillance does indicate a concern, even if it's outside, of course, those recommended screening intervals, and then refer children if there are any concerns to things like early intervention programs like the Infants and Toddlers program, and really highlighting not to take a wait and see approach. And this is also the recommendation through the CDC. Early intervention is so important and key to optimizing development. So wanting to take advantage versus waiting to see if some of these developmental concerns reduce over time. Now switching gears to screening in early childhood. Screeners are brief standardized assessment procedures to identify kids at risk and whether or not they should receive more intensive interventions or evaluations. Of course, of note, screening tools do not provide any conclusive evidence of developmental delays. It does not result in a diagnosis, but it signifies that more should be done. There should be some kind of follow-up. In terms of, as I mentioned earlier, they should be completed by qualified professionals. Those can range from early childhood educators, mental health providers, healthcare providers, and within the context of pediatrics, screening should occur at regular intervals. So at the 9, 18, and 24 to 30 month intervals, as well as for autism specific screening should occur at the 18, 24, and 30 month appointments. And this just depicts the pathway of what this screening procedure typically looks like, when to refer for additional services. So kind of an overview of what we've just been reviewing here. So in terms of reasoning for doing all of these screenings, when we look specifically at behavioral and emotional problems, it's actually quite common in young children. 11 to 20% of children in the United States have a behavioral and emotional disorder. Also 10 to 15% of preschool age children have developmental delays. And then in terms of being globally delayed, 1 to 3% of children We also know that diagnoses like anxiety and ADHD, while not always diagnosed early on, especially when it comes to ADHD, those symptoms often emerge in early childhood. And something else to make note of is that there are disparities in race that can lead to over-identification or under-identification of developmental delays and behavior problems. So being mindful of that as we screen children. Estimates report that 1 in 8 children with identified mental health problems received treatment, and fewer than 50% of those with clinically significant behavioral and emotional problems are detected. While we are able to, we have different mechanisms to be able to identify to a greater degree through screenings. And that's kind of the case for screening in the first place, to make sure that these young children are not falling through the cracks. All right, so there are some myths regarding early childhood screening. So one of these myths is that there's no adequate screening tools for preschool age children, but there are quite a few that have been shown to be valid and reliable with young children. In terms of the training requirements to administer screening, they typically do not require extensive training to administer and to score, and can be utilized by a variety of different providers and staff. A lot of screeners take less than 15 minutes, and many of the ones that I'll be discussing take at most 10 minutes, typically even between like 2 and 5 minutes. So very quick to administer. Another myth is that tools that rely on parent report are not valid. As I discussed early on, we know that parent concerns are generally valid and predictive of confirmed developmental delays later on. So when determining what screeners are appropriate for your practice, it is good to review how reliable and valid the screener is. So is the tool stable, regardless of when, where, and by whom the test is administered? In terms of validity, does it accurately capture what it's supposed to be assessing for? We also want to make sure that its sensitivity and specificity are at appropriate levels. So that's how well the tool identifies children who do indeed, for example, have a developmental delay, and then specificity indicates or kind of guards against misclassifying children as needing additional screening when in fact they're developing normally. We obviously want to use evidence-based screeners. It's good to also consider administration time to make sure that it's feasible within your already very busy practices, and then also the literacy levels of the screeners and how that relates to the population that you serve. All right, so now getting a little bit more into the nitty-gritty of specific screening instruments. First off, in terms of how these can be administered, oftentimes parents can just fill them out. They may receive them in the waiting room to fill out. They can also be utilized as an interview with parents, and depending on the age of the child, they may be able to self-report or can be utilized for younger children through observation of what the child is capable of doing while they are with you. So we'll start by going through specific social, emotional, and behavioral screenings for early childhood. These are several of the screeners that are often used within primary care practices and recommended by the APA. So one of these is the ages and stages. This one is unfortunately does require purchasing, but is a really nice screening tool and also provides surveillance for social, emotional, and mental health milestones. So it looks at things like self-regulation, compliance, communication, adaptive functioning, autonomy, how children interact with others. And it ranges from 1 month to 72 months and takes about 10 to 15 minutes to administer. Another form that is free to use, and the link is included here, and we also have some of the specific screeners as well that can be shared. So the PSC is more of a general psychosocial screening and functional assessment. It looks at things like attention, externalizing symptoms, so like more outward behaviors, as well as internalizing symptoms, so things like anxiety. This is for a little bit of an older age group, 4 to 16 years. It's 17 items and very quick to administer. There's also the SDQ, the Strengths and Difficulties questionnaire. So this screens resilience and psychosocial risk for mental health and social, emotional, behavioral skills or concerns. It looks at areas of conduct problems, hyperactivity, emotional symptoms, peer problems, as well as prosocial behavior. And there are various different types of reports. So they can be completed by a parent, teacher, or as children get older, self-report. And so there's 2 different versions, one for 3 to 4-year-olds and those from 4 to 17 years of age, ranging from 22 to 25 items. This is also free to download and takes 5 to 10 minutes to complete. The SWIC is another tool, the Survey of Wellbeing of Young Children. The SWIC has various different components to it, so you can pull out different screeners from the overall SWIC, depending on what is most beneficial for your practice. So one of those includes the baby PSC. This screens for social emotional health and behavior up to 18 months of age, takes about 5 minutes and is free to download. There is also a preschool version of this for 18 to 65 months, and again is also available for free download. Now getting into developmental screening for young children. First of all, in terms of why we should be monitoring development, screening, of course, is effective. And it's we know that having a developmental delay or mental illness leads to multiple negative outcomes if not addressed early on. And half of children in the general population don't get services before entering school, even if they had been identified to be able to qualify for those services. So we want to make sure that we're, no one's falling through the cracks, again, especially early on. So according to the CDC, 1 in 6 children have a developmental disability. And 1 in 44 children have autism. I know that this rate frequently changes, so may already be outdated. While children can be diagnosed as early as 18 months of age, diagnosed with autism as early as 18 months of age, many aren't diagnosed until they're 3 years old or older. Especially if they're from disadvantaged backgrounds. So this really highlights the need to utilize our developmental and autism-specific screeners to make sure that they are referred for intervention as early as possible. Screening, though, also helps prevent against over-referring, which then, leads to those excessively long wait lists, which we know is already a problem across the state. And then also delayed access to early intervention services. Detection rates of developmental disorders is lower than prevalence rates. So this just further emphasizes the need for screening, and identifying developmental delays can have an impact on additional identification of things like further medical conditions or risk for other medical complications, as well as receiving like appropriate early intervention services, family planning, things like that. And then in terms of some of the specific screeners that are recommended by the APA, we'll go into some specifics here that may overlap a bit with the social emotional screeners, but are different aspects of those screeners, so different version. We had talked about the ages and stages questionnaire a little bit. This part of the ages and stages looks specifically at development. So across communication, gross and fine motor, problem solving, and personal adaptive skills. And it goes from 2 to 60 months and takes about 10 to 15 minutes to complete and is available for purchase. The parent's evaluation of developmental status is also one that unfortunately requires a purchase. It is a parent interview and it screens for developmental and behavioral problems that would qualify for further evaluation. And this ranges from 0 to 8 years of age. Very quick, it's just 10 items, takes 2 to 5 minutes to administer. We also have the PEDS developmental milestones screening version of this. So this again is also a parent interview, screens for developmental and social emotional problems, also goes up to age 8. So here's the SWIC again. So we talked about this for social emotional as well. This looks at cognitive, language, and motor skills specifically. It involves 10 items, takes about 5 minutes, and goes through 65 months and is also free to download. So just want to highlight a couple things regarding autism screening. Routine ASD surveillance should happen at every well-child visit, like we talked about at the beginning. And then the American Academy of Pediatrics recommends that all children receive standardized developmental screeners during their regular well-child visits at the 9, 18, and 30-month visits. And then the additional screening for autism specifically during the 18 and 24-month visits. Now, of course, if a child is at high risk for developmental problems due to like preterm birth or maybe having a sibling with autism, certainly not required to wait for these specific visits and may warrant having earlier screening. Another thing to note about this too is really highlighting that the universal aspect of screening so that it's being provided to all families, which will help normalize versus kind of targeting specific families because of some of these additional risk factors to make sure that no one that potentially would benefit from having the screener completed, again, falls through the cracks. All right. So these are some of the screeners that can help look at specific aspects of autism. I'll go through a couple of them more specifically. So one is the SCQ, the Social Communication Questionnaire, and it's based on the Autism Diagnostic Interview revised. So this is a very thorough autism interview that is done quite frequently during psychological evaluations. It's completed by parents. It's for children 4 years and older and takes 5 to 10 minutes to complete and is available for purchase. Now, to address those specific recommended timeframes when children should be screened for autism, I'm sure most of you are familiar with the MCHAT. So that is highly recommended. It is available for free download. It's also completed by parents, and if there are noted concerns, there's that follow-up component where clinicians then administer additional questions. And this is 20 items, takes 5 to 10 minutes to complete. All right, so now we're going to get into pediatric mental health screening. So this is going to cover screening recommendations for children through adolescence. So we'll move away from the early childhood a little bit here. So to make the case for mental health screening, 1 in 5 children in the United States have a diagnosable mental health disorder. According to the CDC, children aged 3 to 17 years most commonly present with ADHD, anxiety, behavior problems, and depression. And just more overall, 13 to 20% of children in the US experience a mental health disorder each year. The use of a standardized screening tool by pediatric providers is more effective in the identification of developmental, behavioral, and psychosocial issues in children than just clinical assessments alone. So really wanting to utilize the standardized screening tool to enhance that reliability. And then universal screening will, like I mentioned a couple of times already, will reduce the risk of missing children that do in fact have mental health conditions and promote interventions aimed at preventing some of those long-term effects of a childhood mental health disorder. So for an initial psychosocial assessment, we want to, consider some of the concerns that often come up for some of the children or youth that may present in your practice. So according to the CDC, adolescents between the age of 12 and 17 years old, as many as 15% have a major depressive episode. 36% experience persistent feelings of sadness and hopelessness. 18% have seriously considered attempting suicide. 15% have had a suicide plan. 8% have attempted suicide. And 2% have made a suicide attempt that required medical intervention. So those are pretty high statistics and really highlight the importance of screening for mental health, not just for depression, but just to kind of understand the severity of potentially missing some of these children that are struggling with mental health concerns. So here are a few of the mental health screeners that I'll discuss more in depth, and we do have a few more that are both broad in terms of what they assess for, so looking at various different mental health concerns, and some that are more specific to depression, anxiety, things like that. So the pediatric symptom checklist is one that is a little bit more broad. It looks at internalizing, externalizing, and attention problems. So for those externalizing behavior problems, internalizing like depression and anxiety, and then attention problems, so some of the things that we associate with ADHD. These can be completed by caregivers, or if the child's at least 11 years old, they can complete the screener themselves. It's normed for children age 4 to 18 years. It takes about 3 to 5 minutes, and it is one that is free to download. Another example of a more broad screener is the Strengths and Difficulties questionnaires. It assesses 25 different attributes, but breaks it down then into emotional symptoms, conduct problems, hyperactivity and inattention, peer relationship problems, and prosocial behavior. So similar to the last one, can be completed by caregivers, or if the child's at least 11, they can complete it on their own. And it's normed for ages 3 to 17 years. And this one is also available for free download. Okay, so the next one is specifically related to screening for depression. In 2009, the Academy of Pediatrics first recommended universal depression screening for young patients ages 12 to 18 years old. And so this really helped push for the development of freely available depression screeners to make sure that they are being used universally for this age range. And so this is one that has high sensitivity and specificity for detecting major depression. This is completed by the adolescent themselves and is normed for 11 to 18 years. It's only 9 items. It takes less than 5 minutes to administer. And like I said, it's free to download. Another one that looks more specifically at suicide risk within depression is the ASQ, the Ask Suicide Screening Questions. It's a self-report measure as well, and it's normed for children 10 to then early adulthood, 24 years old. It's only 4 items. It takes about 20 seconds to complete. So this is one that if you all are working on any kind of inpatient or emergency settings, is often used, but also frequently used in the outpatient setting as well. So now we have the SCARED. This screens for symptoms of anxiety, more specifically for generalized anxiety, panic, those somatic physical symptoms of anxiety, social separation anxiety, and school refusal. This can be completed as a self-report by the youth or as completed by the caregiver. And it's for 8-year-olds and older. Takes about 5 minutes. It's also free to download. This one is specifically translated into 10 different languages. A lot of these, I should have said this earlier, but a lot of these screeners are available in a number of different languages. Another assessment is the Vanderbilt. This is also free for download. This one comes both in English and Spanish versions. And it looks at a broad range of behavioral health concerns. I know it's often used to look specifically at those ADHD symptoms, but it does also look at disruptive behavior, anxiety, depression, and school performance and functioning. And this is completed either by caregivers or teachers. There's different forms for each. It's for ages 6 to 12. There's a few more items for parents than teachers, but takes roughly 10 minutes to complete. And I think I mentioned this already, but it's also free for download. All right, so, oops. Now that we've gone through a number of screeners, and I know I went through them rather quickly, but we do have reference to access all of those. But I do want to spend a few minutes in what we do after all of these screenings are administered and how we review those results with the children themselves and or with their caregivers. So a few things to highlight following the screener. Like I just said, we want to review those results. We don't want to provide screeners and then not give any follow-up to the patients. Especially when giving, suicide risk assessments, we want to make sure that we're assessing for this and responding, of course, if any items are endorsed, assess for safety, and refer for additional support services or assessments as needed. Okay, so when discussing results, we want to focus on the areas of concern, but also, again, emphasizing that a diagnosis isn't being made at that time. Um, but it's recommended that a child receive further assessment if, of course, items are endorsed on the various screeners, and then ensure that the family knows why they're getting referred for an evaluation, understanding what from the screeners led to that next step. So when reviewing the results of screeners with families, it's important to remind them why you asked them to fill out the screener in the first place, and that it's a place to start a discussion. You also want to make sure to ask caregivers if they have any ideas or concerns while they were completing the screener, and follow up on any responses that they give. Something else to note is if caregivers don't endorse any concerns on the screener, or in older children and adolescents, if it was a self-report, asking them directly, make sure to ask again if they have any concerns and acknowledge that maybe the screener isn't capturing every possible issue that, and there may be something outside of the screener that they're wanting to bring up or address. And then also just making sure to express your willingness to continue to discuss these topics associated with the screener at any time in the future. So if there are positive items or items that are endorsed as indicating that there are some concerns, it's always important to ask for clarification regarding the concerns, as well as how it's impacting the child in various different environments, at home, at school, with peers, as that's going to be important to understanding the severity of these concerns. Again, I've said this, I think, twice now. I'll say it one more time. It's important to remember that diagnoses can't be made just purely off of a screener alone. If a screener is positive, it doesn't necessarily mean that a child's going to receive a diagnosis. And the opposite can be true too. If a screener is negative, it also doesn't mean that there isn't something going on. And maybe, again, the screener didn't capture it, or for whatever reason, the responses aren't maybe matching what's going on for the child. If a screener is negative, but the family or you as the provider still have concerns, it's still appropriate to refer for further evaluation. Screening is the first step in getting children the supports or services that they need. And a full psychological evaluation can then be administered to confirm or rule out any diagnoses. And in terms of other kind of follow-up recommendations, making sure to provide anticipatory guidance, whether that be for development or social, emotional, and behavioral development, and making sure to continue to monitor even once a referral for assessment or treatment has occurred. And when we talk about, that referral for more of a full evaluation in order to receive a mental health diagnosis, that does include some level of observation, a detailed history, and then additional test administrations. So this diagram demonstrates the decision tree for determining follow-up steps after a caregiver completes a screener. So oftentimes parents or caregivers can be given screeners to complete while they're in the waiting room. If it's possible to have clinical staff score and review the results, that's great. If the screener is negative and no additional concerns were endorsed by the family when the results were reviewed, then that's a good opportunity to just provide that anticipatory guidance and rescreen at the next visit or if additional concerns come up. And then if the screener is negative, but additional concerns were endorsed by the family, or through your own observations, depending on the severity of concerns, providing those referrals as appropriate. And of course, when there are positive responses, making sure that families are aware of what the next step recommendations are. All right, well, I am going to wrap it up here so that we can answer, or I can answer any questions. And I see the chat has some things in here, so let me take a look.
Thank you so much, Dr. Gerard, for that wonderful presentation. So as she mentioned, we will move into the Q&A portion of the session today. So please feel free to place any questions that you have in the chat or also in the Q&A function as well.
Thank you for sharing all of those screens.
And we will send all of those screeners and then a list of related resources to you all afterwards with a full recording of the session and the slides as well. So you'll have all these resources.
Yes. Okay, 1 second. Yeah.
It also looks like we have a question in the Q&A that says, what suicide screening do you recommend for under 10 years old?
That's a great question. So while the screeners that I went over are for that specific normed age range, you can certainly use those questions or similar questions to assess for suicide risk in younger children, because the questions are essentially the same. And as we know, there are children that are depressed or have thoughts of suicide even at a younger age. So even having more of an informal assessment can be helpful for those ages. I'd have to look back specifically. I don't remember off the top of my head in terms of those that are normed. But even some of the more global screeners that are normed for younger ages have some of those depression components and suicide risk assessments. So some of these like critical items. So while not specifically just for suicide, there's some overlap. So some of the younger ones that are more global will address that as well. Any other questions?
We'll give it another minute if you have a question.
Hopefully that's a good sign that questions were answered. Thank you.
Okay. It looks like we have no other questions, so we will wrap up today's session. Thank you again, Dr. Gerard, for this presentation, and to our participants in today's session. As I mentioned a little earlier, the recording for today's session, the slides, and a list of related resources will be available on our website next week, and we will also send that out via email. We will send CME and CU certificates to participants by September 20th, which is next Friday. And please remember to take the survey as you exit, which was just placed in the chat, as this is required if you'd like to receive CME or CEU certificates. And we will also send out that survey link via email as well. And stay tuned for future BHIPP trainings by following us on LinkedIn, Facebook, and Twitter. And thank you so much again, everyone, and I hope you have a great rest of your day.
Thank you all.